Good afternoon, ladies and gentlemen. We're delighted you're with us today. We're going to begin our webinar. I'm Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council, and we really thank you for joining us in this educational webinar today. It's hosted, obviously, in coordination with Forvis Mazars, who's not only an associate member of the council, but they're a year-round sponsor of the council. And we've worked with Forvis Mazars for many years, and they're valued friends, especially when we get into issues related to financial and also health policy. Today's topic is going to be legislative changes in the 2026 midterms. And what do they really mean for the U.S. healthcare? We know it's a hot topic, and we have a huge turnout today. Very pleased with the people that have registered. We know that the current administration and Congress are bringing significant changes to healthcare, and some of those policies impact hospitals. And so we are going to look at some of the efforts by CMS, by HHS, and Congress, and we're going to look at how that impacts some of the things that we're doing related to affordability, patient access, and things that we can hopefully work collaboratively on so that as we look at the healthcare policy in the future, it's something that we can help shape and mold. You know, we've got a real expert with us today, Chad Mulvany. He's the Director of Healthcare Consulting at Forvis Mazars. I've had an opportunity to work with Chad before. Early in his career, he worked in healthcare quite a bit, but he was actually with the California Hospital Association. You know, usually I tell you at this point, we're going to put questions in Q&A or in the chat box. But since I mentioned earlier, we've had a great turnout. Put them in as soon as you can, and it could be that we can address them as we go through the presentation. You know, one thing that I kind of give as a qualifier, you know, we're going to have a very open, dedicated, fireside chat type conversation. This is not slanted one way or the other politically. Believe it or not, we treat Democrats and Republicans in our hospitals when they need healthcare needs. What we're going to focus on, what are the current policies? What do we speculate some of the future ramifications of these policies, and how can we all work collaboratively together to do what our ultimate goal is, deliver the very best health care that can be delivered for the patients that we treat. Now, Chad has put together a few excellent slides to help stimulate the conversation. It's going to be a little back and forth conversation, but just remember, if you've got questions, we want to hear them, because no matter what questions we come up with, your questions are the most important. So with that, Chad, what a pleasure to have you with us today.
Well, Steve, thank you. It's a pleasure to be here with you. Certainly excited for the opportunity to both speak with your members and have a conversation with you about these very important topics. And, you know, as Steve mentioned, we're going to go back and forth and have a little bit of discussion. Before we get into the meat of the content, just want to flag for you that we at Forvis Mazars have our podcast, the Achieving Health Podcast. And so it's 3 episodes a month. Usually 2 of them are 20-ish odd minutes with me going through what I think are some of the most important recent events in DC. And then the 3rd episode of the month is where we'll talk with a leader in the healthcare field, whether it's hospitals and health systems, post-acute care, physician practices, to understand the challenges that they're facing, how they're thinking about it. They are insightful conversations, and certainly if you're looking for something for your commute or as you're doing chores around the house, would encourage you to check it out. You know, I think given that the topic that Steve and the Dallas-Fort Worth Hospital Council asked me to talk about, I think it's important that we start with the midterms and kind of thinking about how that might shape what comes after. And I will freely admit that I typically don't try to handicap races anymore. Like a lot of people, I dropped my crystal ball in 2020 or 2016, and I'm still trying to gorilla glue it back together. And also just want to caveat these comments with, given how close many of these races will be, I think it's still pretty early. Starting with the House, Got a little excited. Starting with the House, just to kind of frame it, right now we're sitting with 218 on the Republican side, 214 for the Democrats, and three vacancies. And I think the House, given how close it is the one more likely to flip. And when you look historically, Steve, as you know this, the party that controls the White House on average loses somewhere around 20-25 seats in the midterms. This year, though, I'm not sure that holds for a variety of reasons. Just a lot of different dynamics. But the flip side of that is the Dems only need to pick up a handful of seats to take control of the House. When you look at the preponderance of public indicators, the House tilts modestly towards a Democrat pickup, so they would actually take the House. And kind of as you think about things, it's, you look at a generic ballot, it shows Dems leading by 4 to 6 points, which puts it in a plausible range for a flip. And then when you start to look at like Cook's Political on a report on a district by district, there are roughly 17 toss-up districts, which are those in gray that you see on the slide. And so taken together, the Democrats are likely to pick up a handful of seats, and it's probably where we would land if the election were held today. However, the election's not going to be held today. It's going to be held in November, as everybody knows. And so I think it's close enough that it will be interesting all the way through because, depending on late cycle shocks, whether it's economy, whether it's changes in prices, whether it's international events, I think will have a material impact on the outcomes. I'm curious to your thoughts on the House, Steve.
Yeah, I'm pretty much inclined to agree with you. When I've been in DC and when I've talked to some of the people that do polling, they think it's going to be a flip of the House. They do think the Democrats will take control of the House. As you say, it's early. November is still a pretty good ways away. A lot of things could happen. But for a lot of the reasons that you gave, when you look district by district and you look at some things that are happening, a great example, what happened in Florida this week, where a Democrat won in a traditionally red area that even included the home where President Trump lives. So it's really up in the air. But most people that do this and look at statistics have not talked to anyone that would say, no, it's not going to flip. Most of the people say it's clearly leaning that way, and we think it's going to flip to the Democrats. That's going to be interesting to see, especially you hadn't gotten into the Senate, but when you get into the Senate, it may go the other way. And then you're going to have a divided legislative congressional delegation.
Two thoughts. One, Steve, on the various special elections, you're right. Like there have been a number of interesting results, and I think there is a desire on the media's part to create a narrative about momentum on one way or the other, and that may be true. But I would caution that special elections in particular are unique, singular events. And then, if you try to sort of extrapolate to the national picture from one specific special election, I think that's a risky proposition. And time again, we've seen folks try to predict a wave one way or the other based on the results of a special. And sometimes that wave happens, sometimes it doesn't.
You're exactly right. Even when you look at some of the primaries that happened here in Texas, some people that had been in the House for a long time in the state legislature on both sides, Democrats and Republicans, got unseated. And some of them, it seemed to surprise people, but that's the way elections are sometimes.
Yeah, exactly right. And I think where you were going with your comments kind of as a prelude suggested that the Senate may stay in Republican hands. And I'm inclined to agree with you. If you think about the map today, it's the Republicans hold 53 seats, the Democrats 47. So Republicans start with a narrow advantage. And then when you start to look at your battleground states, in order for the Democrats to pick up the Senate, they have to hold two purple states, two battleground states. So Georgia, so Senator Ossoff would have to win his election. In Michigan, there's an open seat where Senator Peters retired. They would have to hold that, which is challenging unto itself when you don't have a brand name in there. So you got to hold those two, and then you have to pick up 4 more seats. North Carolina, I think, is probably what most pollsters or people who watch elections closely would say is going to be the easiest pickup, and that's because you've got a former governor, Cooper, running for the Dems, who's won a statewide office, running against a former RNC chair, and so that, and given that he's already won public or statewide office once, would suggest that he might have some chops. When you get to Maine, that's sort of looked at as the next pickup opportunity. Obviously, you have Senator Collins, long-seated senator, well respected in the state, served her state well. I think there it's going to really depend on who she ends up facing. If it's former Governor Mills on the Democratic ticket, I think it could be an interesting race because again, you've got somebody who's won statewide election before multiple times, somebody who's highly respected in the state. The other option on the Dem side is a gentleman by the name of Graham Planner, who's a waterman. At the top level, his bio is interesting, and he looks like he could be a fairly compelling candidate given the populist mood of the country right now. However, when you start to dig into some of the things that are allegedly in his Oppo research file, he's got some social media posts that I think could be generally problematic when you get to a general election. When you start to go from there, so if you assume the Dems pick those two up, and again, definitely not a given on either, you then have to pick up 2 more seats. And you're starting to look then at Alaska, where you've got former Representative Mary Peralta challenging current Senator Sullivan. Sullivan may have on the Republican side some exposure because Alaska have benefited heavily from the enhanced exchange subsidies. So he's going to have to fight the affordability issue from a disadvantageous position. Next place where you're looking, there's a possible pickup, and again, going to be a very difficult pickup, would be Ohio. You've got former Senator Sherrod Brown, who lost his seat to the vice president, challenging current Senator Husted. That's going to be a hard slog for the Dems to pick it up. And then from there, if you start thinking about other options, I've heard some folks talk about Iowa because Senator Ernst is retiring. Haven't followed that one closely, so this may just be a knee-jerk because it's Iowa, but that feels to me like it's wish casting. And from there, then you have to think about the Lone Star State. And you've got, as your audience knows, the Republican primary has gone to a runoff. So you've got Senator Corine versus the current AG Hunt. And on the other side, you've got Talrico. And, when you start to look at the polling on that, any combination of that match is going to be incredibly tight.
Yeah, I think, as you look at this, I think we're pretty much in agreement. It's a good chance the House will flip to Democrat, but the Senate's probably going to stay Republican. The message I think we need to get to everyone is vote. Go out and vote. It doesn't matter who you vote for. That's your business. But, it's an important election coming up. Everyone should exercise their right to vote. I will tell you this, Chad, I can't speak for all the other states. During the primaries here in Texas, we had tremendous voter turnout on both sides, Republicans and Democrats. So it's going to be interesting to see in the general election, once we get through the runoffs that are coming up, what is going to be the voter turnout. I think it's going to be very important.
No, I would agree with you, and I would second that message of go out and vote. You can't complain if you don't pull the lever. The other piece of it also, like you said, I think because of the strong primary turnout, that would indicate to me that you'll see similar in the general. So if you assume kind of our base case of House flipping, Senate staying in Republican hands, you end up with, as Steve, you alluded to, divided government. And when you think about even maybe if by some chance the Dems were able to flip the Senate, there's no way they're getting to 60 votes. So again, the outcome is still pretty much the same because obviously with the president and the White House, even if you did hold the Senate, you couldn't do anything under reconciliation. So when you think about what split government looks like, and you think about healthcare, I do think that you end up with gridlock, barring, and God forbid, some kind of public health emergency. I think the federal funding bills for the next Congress are going to be a little bit more of a challenge to get passed, but I do think we'll figure out a way. And I do think that when we have to raise the debt ceiling again in 2027, that could be a little bit more contentious than usual as both sides try to sort out a position that they believe adheres to their values. In terms of healthcare specific legislation, I think you end up with, well, let me back up before we get to possible legislation that could move. I think in this environment, you're certainly going to see more regulatory activity from CMS, given that Congress won't be able to pass much related to healthcare. And then also I think CMMI continues to be important in terms of pushing forward the value agenda, as it always has been. When you think about things that could pass, I think, you might see some smaller bore efforts to expand Medicare site neutrality. As we sort to take the potential of more bipartisan legislation off the issue. I don't think the risk of something like a MedPAC recommendation on site neutral or repealing the Section 603 grandfathering is as likely with neither party holding a trifecta. And again, we'll talk about this more, but I do think that we will continue to see more rulemaking expansion of site neutral through CMS and through the OPPS rules. The other piece is I think we're going to continue to see 340B scrutiny. However, when I think about legislation that probably has the greatest chance of potentially passing, I think it will be whatever product that the Senate Gang of Six can put together. However, my understanding is that piece of legislation is still hung up on coming to grace on a definition of patient that all sides can agree on. And so, I expect that this will continue to be sort of a simmering issue into the next Congress.
Yeah, I think you're right. And I think in a few minutes, we're going to get into more specifics and I'll weigh in a little more heavily there. But I agree with everything that you've said. And, there's even talk of a potential another budget reconciliation bill, which only requires 51 votes.
As the weeks have gone on, I think the likelihood of at least an attempt at a reconciliation bill have increased. Even going back to shortly after the One Big Beautiful Bill Act or HR 1 passed, you were seeing Republicans in the House start to talk about what a second iteration of this would be. And up until recently, the president has not been inclined to be supportive of that effort. However, there are a rotating list of issues now that I think maybe have brought him around to the need for a second piece of legislation. And I think the package could potentially include some combination of elements of the SAVE Act, the Voter ID Act, that could pass muster with the Senate parliamentarian. There is still talk, although that the deal that they had that was in the works around funding the Department of Homeland Security seems to have faltered, at least for the moment. But there was some thought that maybe that you could come to a bipartisan agreement on funding most of DHS while maybe stripping out additional funding for immigration and customs enforcement and including that in a reconciliation package. Certainly, we understand that the Department of Defense will need additional funding for the troops. And, once you start to move a package like this, it starts to become a bit of a Christmas tree because it will likely be the last bill that moves beyond in my opinion, continuing resolution that kind of punts the federal funding for Fed Physical 2027 until after the election.
Right.
And so, when you think about what might end up in a reconciliation package from a healthcare perspective, I think the blueprint to watch is going to be the House Republican Study Group's blueprint. And so that includes $172 billion in cuts for Medicaid site neutral payments, kind of following the president's directive and redirecting the ACA subsidies away from health plans to individuals into what are being called freedom accounts. I think you could see an expansion of transparency, so price transparency efforts on both the health plan and provider sides, potentially with some type of upfront sort of guarantee of price, which is something that Cynthia Fisher from Patients' Rights Advocates has been very strongly in favor of, and she's been quite influential. Maybe possibly using a direct appropriation for the cost sharing reductions, which would limit or eliminate the practice of silver loading. And then also some things around program integrity. So codifying the president's public charge rule, which would have an impact on hospitals that treat large volumes of immigrants, making all non-citizen foreign nationals ineligible for Medicaid, SNAP housing, and other benefits, and imposing a 20% FMAP penalty on states that allow undocumented immigrants in Medicaid. And then kind of on the insurance design side of it, expanding access to tax advantaged options. So looking at expanding tax advantage status for ICRAs, or the individual health coverage, HRAs, association health plans, and other sharing ministries. I guess Steve would be in. Oh, I'm sorry, go ahead. Would like your thoughts.
No, what I was going to do, I was going to weigh in. What I've been hearing, especially, with the conflict going on in Iran, there's going to be probably a lot of discussion on how do we cut expenses. And that's why the budget reconciliation bill, even a couple of Republican senators, I think Senator Rick Scott and Mike Lee, both said, I'm not sure we're going to get 51 votes if we come back, but they may rethink that now because they're going to have to look at how do they cut expenditures because of the Iranian conflict. And what I've heard is very similar to what you've heard. Site neutral Medicaid was going to be an area they really were going to focus on. Also ending the ACA 2010 Prevention Wellness Fund, which was going to save X number of dollars. Putting insurance options out on the exchanges that don't necessarily comply with the ACA benefit and coverage rules. And then, of course, you mentioned health savings accounts. So there's a lot up in the air right now that could happen. It may not happen. And I think that there are other factors now that at one point, no way are we going to have another reconciliation bill. I'm not sure that's the case now.
I would agree with you. Earlier this year, I would have written it off completely. Now I think I see a window with all of the different issues. And you mentioned the challenges in getting to 51 on the Senate side. I think the getting to 218 on the House side will be incredibly difficult because Speaker Johnson's margins are tight. Last time I checked, because of vacancies, he's got one vote to spare. That doubles in April when the runoff for former Congresswoman Marjorie Taylor Greene's seat occurs. But even still, when you think about the HR 1, the tax cuts and the force of the president's personality held the caucus together for that. And certainly when you think about tax cuts, it seems to be sort of a common rallying cry, a way to reform the tax system. This time around, while there is strong support within segments of the Republican caucus for each of the things that would sort of be the unifying or the core provisions in a reconciliation package, if it were to come together, I don't know if any of those things completely unify the caucus. The other thing to think about is just from a House standpoint, you have one member who has significant health issues, so you start to get into potential attendance issues there. You also have some potential issues with attendance because of the election coming up. You've got Republicans who have lost primaries or who may have decided to retire, who may, for lack of a better term, check out. And you also, again, have some who are going to be more worried now that once they're through their primary, about how a vote will be taken in a general as opposed to possibly being challenged by somebody further to the right of them in a primary. So I think the ability to thread the needle here will speak volumes, if it can be done, about both Senate Majority Leader Thune and Speaker Johnson's skill to manage their caucus.
Right. Excellent points.
When you sort of start to think from potential legislation and looking at some of the impacts to Texas, when I think about kind of the 6 things that would be most significant from a health system perspective, I think we have to start with the exchange subsidies. And while there were efforts in Congress by a bipartisan group of moderates, those efforts didn't pan out for a variety of issues. And what's been interesting to watch is that and we can talk about what the expectation was in a second. But contrary to initial expectations, initial enrollment in the exchange in Texas was up slightly compared to 2025. So starting off on a good foot. However, Steve, as you know, the number that matters most is the number of effectuated enrollments, which we won't know until the end of March. And my understanding is that CMS leadership at a recent conference for health plans told the audience to expect those numbers soon. When you get into the expectations for Texas, one of the think tanks in DC projected that Texas would see an increase in the uninsured of around 920,000 if the enhanced exchange subsidies expired. That would increase the uninsured rate by roughly 3%, translating into an increase in uncompensated care statewide of about 1.5 billion. To me, any increase in the uninsured as a result of this is really only going to be part of the story. First, it doesn't tell us who bought down to a bronze plan and now isn't receiving the cost sharing subsidies. And just kind of as a general rule of thumb, what I'm hearing is $7,000 is kind of the national average deductible for a bronze plan in 2026. So when you think about median household incomes, this essentially leaves individuals uninsured for everything, but with the exception of a catastrophic situation. The other thing to think about is, and this is going to be important given that we're still within that 90-day window, is that, when you are enrolled in the exchange, particularly when you are auto-enrolled, you have 90 days to pay the first premium to effectuate coverage. So there's a good possibility that there are individuals that are in those coverage numbers right now that have not paid their first premium, may not pay their first premium, and may sort of ignore those texts that they get or however their bill comes to them. And so the thing to think about from the health plan perspective is my understanding is plans will pay the provider for services during the first 30 days without payment. If the service occurs day 31 or thereafter, they'll withhold payment until the premium is paid. And so for the hospitals on the line or on the call, there are a couple of takeaways here for this. One, and this has been true, is always true, but make sure you've got good processes in place to verify coverage. And I know some states, particularly with exchange products, will make it available so that you can see, and Arkansas is the example that I'm thinking of, for an exchange enrollee who has actually paid the premium and effectuated coverage and who hasn't. And so if you have access to that kind of data, I think it's going to be important to educate the patient on the need to pay the premium. The other piece on this also is thinking about how you improve upfront cash collection processes for non-emergent services. And then on the back end, I think it's going to be necessary to really look through at both your financial assistance policies to make sure that they still meet the needs of the community and also reflect the organization's financial wherewithal. And I think also going and pressure testing the mechanisms that you have to communicate the availability of financial assistance and making sure that individuals who qualify for your financial assistance policies are getting access to it and receiving those discounts where they are eligible for it. But Steve, would be curious as to what you're hearing about the exchanges.
I'm hearing very similar to what you've heard. And, a lot of people don't understand why Texas would get hit so bad on expiring enhanced premium tax credits. It's because we didn't expand Medicaid. And since we didn't expand Medicaid, a lot of people enrolled in the health insurance marketplace, and they had enhanced premium tax credits to help pay those premiums and have coverage. What I've heard anecdotally, and we've got to wait till we see the results from CMS, a lot of people did enroll. The debate was going right down to the wire. Are we going to include enhanced premium tax credits or not? And ultimately, the decision was made not to include them in the legislation, and they expired. And so people went ahead and signed up. But what's going to be interesting is when they get that premium notice, are they going to be able to pay it? And if they don't, what is going to be their alternative? We're very blessed that 2 out of 3 people in this country work for small business. Most small business don't have group health insurance plans. And many of the small businesses, their employees used the health insurance marketplace, so use it to get their health care coverage. So it's gonna be real interesting to see the overall ramifications and the fact that we already lead the nation with the highest uninsured rate. This is potentially going to make it worse. And a couple of things are going to come out of that, Chad. As you well know, many people then will postpone prevention, wellness type visits. And when they do get sick, they'll end up going to the emergency room, which is not where you should get your primary care. And they probably are going to have an acuity level much higher than they would have. So there's still a lot to be seen, but anecdotally, I'm hearing it is going to increase the uninsured.
Yeah, and your point about where people get their care when they're uninsured is well taken. I mean, the ED is obviously the wrong place for primary care, but by the time they get there, it's going to be far more expensive, and the audience knows this very well. So won't dwell too much longer on that, but I think that is a great point.
Yeah, the other thing, I know you don't have it on the slide here, but we're hearing a lot about affordability. And I know the House Ways and Means Committee brought in insurance people. They brought in Rick Pollock from the American Hospital Association, and rightfully so, to ask about affordability. Here's the thing that many times when you peel back the onion, people don't realize. Workforce still is a big expense that's facing providers. If you look at a P&L for an acute care hospital, 50 to 60% of the direct expenses are salary, wages, and benefits. We're very people intense. And we've got some things impacting it, like H-1B visa, where the fee went from like 5,000 to 100,000. A lot of those foreign trained docs do a lot of work in research. They do a lot of work in care, many are specialists. And in our rural hospitals, many of the rural hospitals are staffed with foreign trained docs. So you've got a lot of little things going on and moving parts that really impact you. The other thing, according to the American Hospital Association, 7.5% increase occurred in 2025 in hospital cost related to caring for patients. The price increases did not go up that much. The other thing that I touched on earlier, it looked like in a survey they did from 2019 to 2024, 36% of the hospitals reflected treating sicker patients. Now, they did adjust it for COVID during that period as well, but it was a significant increase. The other thing, hospitals are spending a lot of money on administrative things like appealing denials. And the more denials that come in, generally, if you appeal it long enough, the provider does in fact get reimbursed, but you look at the expense. According to the American Hospital Association, hospitals spent $43 billion just in 2025 appealing denials. That's a lot of money. If we could work collaboratively with the payers on how we can reduce the denials and make sure that we got proper outcomes, that would help remove expense. And the other thing that I think the average person on the street doesn't think about, but you've worked in hospitals, and I have too, prior to being here. 56% of the hospital cost, again, according to the American Hospital Association, are tied to service lines where we lose money. And you may go, well, why are you doing a service line where you lose money? And I know a business person, if you were a car dealership or something, you would say, well, why are you doing that? Well, some of those service lines include behavioral health, OBGYN, burn centers, infectious disease. We can't just shut those services down because we've got to treat the community and we're an acute care hospital. So all of those factors come into why it's so costly. And that's why if the uninsured rate goes up and people come to the emergency room, not only do you have a loss of revenue, you've got an increase in expense. So I didn't mean to get into the affordability issue, but I thought it was a good time to touch on it.
No, all of those comments are spot on. And I think the other thing that I just want to, we could sit here and talk about each of those things that you laid out, but I want to specifically touch on denials because, when you think about administrative burden and the fact that there's nothing through that process that truly benefits a patient's clinical care. In many instances with denials, you have to get a physician involved. And obviously, we already have physician shortages in many areas of in the country. These are highly skilled individuals, and now they're having to get involved in an administrative activity that they didn't go to school for. It's not what gets them up in the morning, and you're taking them away from time for patient care. So we're reducing access further, and we're contributing to physician burnout. And so, if I had one wish of things that I could solve immediately, I think the denial crisis, like you just sort of raised there, working collaboratively with health plans would be one of them, because I think you could see multiple beneficial effects just from that.
Right.
So moving on to the next item, 340B, I think there are really four issues in terms of the program. Obviously, starting January 1, we have the 0.5 percentage point recoupment on Medicare outpatient payments as a result of CMS's efforts to reduce payments for separately payable Part B drugs. And that went into effect January 1st. That was obviously a result of the legal challenge to CMS's prior policy. One of the things that I think to look at and watch for as you're budgeting for the coming year, if you're in your budget cycle, is that CMS in the proposed rule for 26 had initially proposed to increase that to 2%. However, they backed off it in the final, so they left it at the 0.5 percentage point, which had been previously finalized, but indicated that they might be coming back to it in the future. So as you're trying to put the numbers together for your budget, I might contemplate whether you need to adjust your assumptions for outpatient Medicare based on that. The second item is the hospital outpatient drug acquisition cost survey, and that's currently live. You probably are aware that CMS has extended the deadline to April 7th. So it will be interesting to see in the 2027 OPPS proposed rule how CMS uses that data and whether it brings back the separately payable Part B reduction for 340B acquired drugs. Because obviously the reason why the Supreme Court struck down that policy previously wasn't the policy was impermissible. It was just that CMS grabbed data from MedPAC to affect the cut or to inform the cut, as opposed to using a survey, which is what the statute commands it to do. Next item under 340B, there's obviously a lot going on in this space, is the 340B rebate model. That was withdrawn by HRSA as a result of a court case filed by the AHA in Maine. Was withdrawn not because that court in Maine or any court has found it to be impermissible, but the court in Maine found that HRSA violated a couple of the provisions of the Administrative Procedures Act. And so what HRSA is now doing is going through the steps it needs to per the APA to reissue the model, and that would be my assumption that we'll see it probably later this year. To that end, it has issued a request for information related to the rebate model. And so this is one of the steps that will go into rulemaking to avoid that APA issue that tripped it up. And so I would encourage everyone to respond to that request for information if you're a 340B covered entity specifically. And some of the areas where HRSA is requesting feedback is around the administrative costs that are going to be borne by covered entities, the additional costs that are going to be likely as a result of that rebate model. I would talk about the impact on staff roles and responsibilities. That's something else they're asking about. What types of IT system, software, and data infrastructure will be necessary to support the pilot? And then additional costs tied to entity types such as rural and or safety net hospitals, community health centers, etc. And also asking about guardrails to prevent inappropriate manufacturer denials. And then, effects on timing of payment and cash flow. The public comments, as I mentioned, are due on April 20th. Those have also been extended. So that's the extended due date. And again, I think probably it's worth having a conversation if you're a covered entity with your state hospital association, your regional hospital association, the AHA, your national associations, to think about putting together some thoughtful comments and really try to highlight the considerable unreimbursed costs that providers will incur when they have to administer a rebate model, particularly around unnecessary data submission elements. I think it's important to have a discussion around the impact that a rebate model, particularly if it reduces inappropriately the discounts that covered entities receive on access to services, particularly for at-risk populations. The need for a robust appeals mechanism. I think one of my major concerns with the initial iteration of this was that HRSA did not include a mechanism by which covered entities could appeal manufacturer denials.
Right.
And then the other piece on this is I think there needs to be some mechanism for manufacturers to pay interest on the rebates, because particularly for large facilities that dispense high volumes of 340B covered drugs, there's going to be a significant float that will benefit the manufacturers as a result of this.
Yeah,
Go ahead, Steve.
No,
Yeah.
I didn't mean to interrupt. I thought you had finished. I apologize. Everything you say is right. And for people that aren't familiar with 340B, the way it works now to help people in an indigent population, the cost of the drugs are reduced and discounted. What HRSA has been toying with is, why don't we charge full board for this, and then you apply for a rebate? And that may sound good, but if you apply for the rebate, and I don't mean it the way it sounds, but if it's treated almost like a denial where you didn't do this, you didn't do this, you need to jump through this, you need to do this, dot this I, cross this T before you get your rebate. I talked to a large safety net hospital that'll go unnamed, but they're all in Texas, and their CEO told me if the 340B rebate program went in, it could impact cash flow $70 million. $70 million. That is going to be tough on safety net hospitals. Many of our rural hospitals participate in 340B. And there's an organization in Texas called Torch, and it's led by a great guy, John Henderson. John Henderson just does excellent work. John, I saw a statement he made that roughly a third of the hospitals in rural areas in Texas, and we've got roughly 153, have trouble with next month's payroll or having enough money to cash flow. Well, if you hit the 340B program, and from what I understand, there's probably going to be another test rebate model, but Chad, I heard it's going to expand it from 10 drugs to 15 drugs, and that's going to have even more of an impact. So this is very important. And to follow up on what Chad said, the American Hospital Association has developed a nice template letter that you can use to cover a lot of the points that Chad mentioned out that are unique to your specific hospital. Are there some problems with the 340B program? There are problems with any program, but we don't want to abandon the entire program. Let's work together and make it best for everyone, and ultimately the patients that benefit from these drugs.
No, Steve, all great points. And just to put this in perspective, our internal subject matter experts estimated that the initial rebate model could impact up to 10 to 15% of a covered entity's discounts. So if you expand it by another 5 drugs, start to do the permutations on that, that starts to become a pretty significant chunk of the savings. I think the other thing, and appreciate you sort of stepping back and providing some of the bigger picture on what the program is. I think it's important to remember that the 340B discount program is manufacturer's discount. So this isn't money that's coming from CMS. This isn't money that's coming from the Treasury. So the cost to the taxpayer, there is none. I think probably in the spirit of time, maybe move on to state-directed payments. I think everybody's familiar with the changes that are required in OB3. And my understanding is based on the initial guidance and the subsequent guidance that has been provided that Texas has been grandfathered. So those cuts won't kick in. That 10% reduction down to 110% of Medicare won't kick in until state plan year 2028. I think at this point, really what we're waiting on is more detailed rulemaking from CMS. And that rule went to OMB, the Office of Management and Budget, which is where rules go for review before they're released, at the end of February. And so I would anticipate that we'll probably see that rule, which will provide us more guidance and help us sharpen our pencils on the impact estimate, probably sometime early to midsummer. So, keep your phone handy if you go on vacation at the lake or wherever. The other thing that I would add is in terms of things that, I'm personally looking for out of that rule to kind of help sharpen that analysis is one, how is CMS going to define what the specified total published Medicare payment rate is?
Right.
That could be material depending on who you are. And then the other question that I have that's sort of jumping off the page is that 10 percentage point phase down. Is that 10% off the amount from your last completed preprint? So, it's a level 10% each year, or is it what I'm calling a rolling 10%? So it's 10% off the base amount, then 10% off the next year's amount, then 10% off the next year's amount. And that matters in terms of how long it takes you to get down to that 110 for Texas.
Yeah, the one thing we're blessed with in Texas, our executive commissioner at HHSC, Stephanie Muth, is a great individual. She works hard. She tries to have an excellent relationship with CMS. And hopefully, as we work through some of these state-directed payments, they get complicated, and you get into, I won't get into the weeds, into CHIRP, into, Atlas, and all of that. But there's a lot of work to be done. But I have faith that she's going to do the best she can in working with CMS.
Yeah. When you think about site neutral and just want to kind of touch back on, so I alluded to the MedPAC recommendation earlier, just to put the impact of that in perspective. An analysis commissioned by the Coalition to Strengthen America's Health Care looked at that recommendation to pay 66 procedures at the rate in which the service most frequently occurs. And it projected that, so, if something was most frequently occurred in a freestanding setting, it'd be paid at the freestanding equivalent rate. If it's provided at the ASC, they would come up with an ASC equivalent rate. And just looking at those 66 procedures, it projected that over 10 years, it would reduce hospital reimbursement by 182 billion. So that would be 12 billion in the first year. Rural hospitals would face 26, would account for 26 billion of that over that 10-year period. I think just kind of stepping back from a policy perspective, the advocates for site neutral on the surface have a compelling argument because it fits on a bumper sticker, right? Same service, same price is the mantra. However, that mantra overlooks two very important factors. One, site neutral payment assumes that CMS, through the physician fee schedule, is paying physicians appropriately, that they have maintained and updated the conversion factor that is kept up with the costs of running a practice. We know that not to be true between macro and also the sustainable growth rate. And I think that in part is one of the reasons why we have seen a retrenchment or more physicians leave kind of the private independent practice model for other models. So kind of assumption number one is not correct. Assumption number two is that the cost to provide care in a freestanding setting is the same as it is in an HOPD. And we also know that not to be correct. When you look at the analysis of claims data, the patients who tend to get care in an HOPD are more likely to be dually eligible, are likely to have multiple chronic conditions like diabetes than in the freestanding setting. And then you start to talk about all of the different regulatory requirements that aren't present in a freestanding setting that are present and costly in an HOPD. So just kind of want to level set that background. I think, as I mentioned in my comments around the election, I think the risk on site neutral over the near term, so through 2028, is more going to be on the regulatory side than the legislative side. And I do think when we get to the 2027 proposed OPPS rule, we may see CMS kind of use that volume control method argument, the same argument they use to make the clinic visits and off-campus HOPD site neutral, and this most recent year, Drug Administration Services site neutral. And if you think about where they may go next, I think it's probably going to be imaging services, or maybe thinking about bringing that clinic visit policy onto the main campus. At least those were two areas that CMS asked for feedback for in the 2026 proposed rule.
The one thing I'll add, you touched on the site neutral payments and the cost, and how, ultimately it could affect all hospitals, all HOPDs, and it certainly can affect rural hospitals. The one thing I do want to add here, and I don't think we have it on the slide, um, when the One Big Beautiful Bill passed, one of the things, and I think Senator Collins from Maine was really the catalyst for this. She worried about the rural facilities. So they added $50 billion back to help rural hospitals, which was certainly appreciative that that was done. But that was spread over 5 years. So that's 10 billion per year, and it's for the entire United States. Uh, Unfortunately, some states have more rural than other states. And I'll give you a great example. In that first allocation, it looks like I think Texas is going to get $1.54 billion over a 5 year period, which is good. But if you look at the rural population, the per capita is like $66 per person. And I think if you go to Rhode Island, it's like 5,000 per person. I think that might have been an unintended consequence of how the calculations were done. But it goes back to rural hospitals razor thin as far as cash flow, and we got to do everything we can to protect them. Sorry, I wanted to insert that.
Yeah, no, great comment. And certainly, it's an important conversation to have. And, I think it'll be interesting to see how Texas, like the other states, uses that funds and the type of care delivery transformation that they are able to invest in based on how they deploy the dollars. But I think, one of the we've been talking about workforce. I think one of the commonalities that we've seen across state applications has been investments in workforce, and hopefully those can come to fruition to provide to create more residency slots, support nursing programs, and really even start to think about pre or high school level courses or initiatives to get people interested in careers in healthcare and kind of bring them along through the track to get them into the system as techs or what have you. Because across all ends of the labor spectrum, we certainly do need more workers that are in this field. And, one of the other things that I'll add is everyone on this call knows hospital jobs are good jobs, quote unquote, good jobs. They come with insurance. They come with 401ks. They typically pay a good wage for the work. So, it's important to hopefully get people interested in those careers. The next item I want to cover is in the OPPS 2026 rule, the expansion of the ASC covered procedure list. And so CMS is phasing out the inpatient only list over the next 3 years. That's going to be completed by 2029. And so the first tranche that's being removed is 285 CPT codes that are mostly musculoskeletal. CMS is going to continue to exempt procedures that have been removed from the IPO list or the inpatient only list for medical review for a period of time to assess. And so you won't get sort of 2 midnight rule scrutiny until the secretary has an opportunity to determine the service or procedure is more commonly provided in the Medicare population in the outpatient setting and figure out what appropriate review criteria might look like. When we get to the ASC side of the house, or the ASC setting, the ASC covered procedure list was expanded by 560 services, so 289 procedures in general, and then 271 that were removed from the IPO list. I think for hospitals, there are a couple of different things here to watch for. I think you do have a potential for there to be some differential referral patterns for physician-owned ASCs, where you might see healthier patients ending up in an ASC and sicker patients ending up in the hospital. And I think the concern there is that particularly for Medicare, you're not going to see the DRG rate for the ones that need to be treated on an inpatient basis or even the outpatient basis on the APC for the outpatient side keep up with the cost of providing care, just given the way those rates are set based on data that's somewhat old. I think the second piece of this is just you have the straight up loss of the add-on payments. So when you have inpatients move to the outpatient setting, even if it is your outpatient setting, you're going to lose the disproportionate share payment that tries to compensate for caring for safety net populations. You're going to lose the IME add-on, which compensates for the cost of teaching the next generation of physicians. And then finally, I do have some concerns about Medicare Advantage. While they are supposed to adhere to the fee-for-service rules of the road for things like site of service review, they frequently have their own interpretations that are not the same as what or how CMS interprets things in the fee-for-service world. So I think that may set up for some more contentious MA contract negotiations.
Yeah, I don't disagree with you. Chad, I think you covered that subject very well.
Last thing I want to cover, and hopefully we'll have a couple minutes for questions, is the requirement in the CAA at 2026 that starting January 1, 2028, hospitals must submit a provider-based attestation for each off-campus department, and also for services billed after that date, off-campus HOPDs will have to bill under a separate MPI. We are waiting on rulemaking for that, and my best guess is that we'll probably see the regs for that in the OPPS 2027 proposed rule. That, in terms of timing, makes the most sense. I think the thing that concerns me is this is going to be a heavy lift both for hospitals and for the MACs. When you think about it, was having a conversation with a mid-sized health system in the Northeast, and they were starting to get a handle on their sites that they would need to submit for MPIs for, and depending on how the regs are written, the attestations. And they think it'll be over 300 different outpatient sites that they're going to have to process. So that's just one example of a relatively, like I said, mid-sized health system. So the administrative burden on this is going to be significant. I think if I were sitting in a C-suite in a finance function for a health system right now, I would start preparing for this now. I would get that inventory of facilities that I need MPIs for. I'd be breaking out. Many organizations have already filed attestations. Hopefully, when CMS writes the regs on this, they will recognize that a prior submitted attestation will meet the requirement. But go through those attestations where you've got them and make sure that all of the data is up to date and current. You've got your files in order in case CMS comes out with a requirement that you submit that information. And I think you need to be watching the OPPS proposed rule, assuming that that's where the regs come out for what the next steps are. But I do think you need to be ready to submit that information as soon as possible.
You're right, Chad. And the National Unique Patient Identifier that they're asking people to do, there's already an identifier there. It's kind of a duplication. I do know the American Hospital Association is working closely with some of the people in CMS and working to say, do we really need to do this? We understand the intent, but it is going to be a tremendous, as you indicated, I've talked to several hospital systems that have clearly a lot of these HOPDs that are going to need this national patient identifier and attestation. That's going to be a lot of work. And I'm not saying it's not good. I'm just saying, is there any way we can compromise on it? And we'll see.
Yeah, and yeah, I completely agree with you. And just kind of the last comment on this is I remember very early in my career when the attestation first became an option, when I was still a green consultant, one of the things that I did was run around and help put those attestations together in the documentation. And for some of our clients, for one site alone, it was a 3 to 5 inch ring binder back in the day. And it had all the different information in it in one place. So this is not an undertaking to be sniffed at. So with that, Steve, be interested in any questions the audience has or any closing comments from you.
Yeah, I don't see any questions. I do have one somebody submitted to me earlier, and I think you touched on it during it. But for the people that joined us today, thank you very much. Again, this is not political. This is not Democrat. This is not Republican. We have a great relationship with HHS. We have a great relationship with CMS. I think the main thing is, as we look at legislative and regulatory changes, how do we sit down in a collaborative spirit and work through the best way to implement them? And hopefully and ultimately, it'll have the best outcomes associated for the patient. And I think everybody would be in agreement on that. Chad, the one question that came in, and you kind of touched on this, But as you look at your crystal ball, and I know you do work all over the nation, but as you look at Texas, what is your overall advice on how hospitals prepare, especially the financial impact of expiring enhanced exchange subsidies, the state directive payment phase downs, potential expanded site neutral policies, uncompensated care, and access to services? That's a lot in one question, but somebody asked me to ask you that.
It is a lot, but I'm happy to take it. And Steve, also, I just want to second your closing comments because I think you're right. I think as long as we all focus on the patient and making sure that the system that we have delivers the best outcomes in the most efficient manner, that's the thing we all care about. In terms of the question, I touched a little bit on the expiring exchange subsidies, and so I think there it's a revenue cycle process of understanding the patient's insurance or lack thereof, educating about other coverage options, educating about the availability of financial assistance, and also making sure that financial assistance policy meets the needs of the community. In terms of the cuts, whether it's for the state directed payments, whether it's increasing uncompensated care, I think you have to do a couple of things. And one is really performance improvement, continuing to look at just every aspect of the organization and its operations. I think one of the things that really struck out for me, and we just are releasing this piece of work today, but our 2026 Mindsets Executive Survey for health, or survey of healthcare executives, finds that in general, health systems are setting a roughly 2.5% performance improvement goal per year, which is that is an aggressive number. However, the median response back was that only 40% of that target is actually achieved. And the thing that is inhibiting organizations from doing it, it's not a lack of good people trying to do the right thing. It's that there's not enough time to sit down to look at the data. That sort of the daily fire drill, if you will, kind of prevents specific and sustained performance improvement effort to identify areas where you can take cost out, that you can improve throughput, that you can improve efficiency, and ultimately end up with better patient outcomes. So I think that's one place to look at it. And then also, just given the scale of the cuts, I think you have to look on the revenue side, where there are opportunities to collaborate with those in your community to continue to provide access to services. And so thinking through what collaborations might look like. And one of the things that I think is most interesting about the RHTP, the Rural Health Transformation Program that we touched on earlier, is that throughout the initiatives across each state, one of the common themes is that they are designed to drive collaboration, not just between hospitals, but between other providers and other entities within rural communities to help improve access, help improve outcomes.
The one thing I will add, Chad, many of you may or may not know Stephanie Carlton. Stephanie is a very nice lady. She actually was working here in Dallas with McKinsey, and Dr. Oz chose her to come and work with him at CMS. And she serves in a variety of capacities, but one is kind of chief of staff. And I talked to Stephanie not long ago, and I said, Stephanie, as you've worked with Dr. Oz now, what would you say is one of the real underlying themes that he stresses? And kind of what you were just saying, Chad, he's really big on care coordination, use of technology, use of innovation, and ultimately, how do we get the best patient outcomes? And I don't think any of us could disagree with that. I mean, that's really what we want to do is coordinate care, do the best we can for the patient, and come up with the best outcomes. So, as we work through legislative and regulatory changes, I think the main thing is let's work collaboratively together. And if we do so, and we do what's best for the patient, we're going to truly be successful. Chad, it's been so much fun. We're going to have to do this again.
I know. I always enjoy chatting with you and always come away smarter for the conversation. So thank you. I appreciate the opportunity.
We don't have any questions pending. So if you don't mind, if you have any final words, or we'll go ahead and conclude this webinar.
I think your call about care coordination is enough, and I certainly agree with it. And I think those are wise words to end on.
Well, thank you. And thank you for being here. And for all the people that tuned in, we're glad. The other thing, Chad, that many times people register and things come up. Chris records this and he's going to make this available to all the people that registered. So we want to thank everyone for being a part of this, and we hope you have a great afternoon. This
Thank you.
webinar is concluded.